I'll keep my comments brief, and basically, I'll just raise a few points from my perspective that I think some of the messages that I'm taking home from here, as well as some of the challenges that we face in the context of research in mental health. So the first point that I wanted to talk about is that what is the role of science in either enhancing or decreasing stigma? And at one point, I was quite convinced that it is science that will help destigmatize mental illness, because if you can prove to people that that's a brain-based illness, then it'll make a difference. But my take on it is not as clear anymore. The more I read, there's more controversies in that domain, because sometimes when you know that it's a brain-based illness, that maybe it contributes to stigma as well. It eliminates certain aspects of stigma, but it induces other kinds of stigma. So how do we use science, and can we use science to help destigmatize mental illness, and how do we do that? So that's a challenge. The other issue that I wanted to raise, and then maybe at the end of the session we can all discuss these issues, is that even within the sectors which is engaged in research, or sectors that are involved in improving mental health, globally speaking, there are camps that stigmatize each other. So we heard about how different types of professionals in the sector of service delivery might have different perspectives and stigmas against each other. Similarly, but even probably more profound, might be the stigmas that exist in researchers who are doing research in mental health versus clinicians who are doing practice. And they're both working towards the same end objective, but sometimes there are tensions there. You would see, oh, the researchers in their ivory towers or the clinicians in the trenches. Those are the visualizations that exist, but the reality is very different. We're all working towards the same objective. So why are we butting heads rather than fusing together and enhancing? At the end of the day, we want to improve mental health for all. So those are the other kinds of stigmas and biases that I see very loud and clear, and very difficult to overcome. Some of the opportunities as well. Recently, we have established a depression research center at the Royal, and at the same time, we are simultaneously creating a national network of depression centers. So here's an opportunity to influence not only the approaches that we have for diagnosis and treatment of depression, but also here's a beautiful opportunity for us to help eliminate some of the stigmas that exist, because now we would have a national kind of a reach in training young people, and to train them about the issues of stigma as well as science of research, but also in terms of penetrating evidence-based treatments, or what's new and coming out, and how can we share some of the expertise we have, and hence also eliminate some of the sort of stigma and jealousies that may exist between different centers across the country. Because again, it is not, depression is not an Ottawa issue, it is not an Ontario issue, it's not even a Canadian issue, it's a global issue. So I think that the more that we can come together, that would be another opportunity for us to help eliminate stigma or do something about it. The other issue that we identified today, but really there was not much of a discussion, was this issue of stigma that takes multiple perspectives. And I'm very interested in the aspect of what we call double stigma, that is stigma that a culture brings based on the cultural biases, and the stigma that may exist in the society, in this case, dealing with mental illnesses. So when you have a young person of an immigrant family, of a visible immigrant family, who is trying to merge into a new culture and having those challenges, how does stigma of mental illness that now comes not only from the culture that he's trying to become a part of, but the culture that he's associated with through his parents, how do those conflicting or synergizing influences impact on the well-being of this young person? So this is really a very critical issue, and it's not really, I don't see it being addressed in our country. So that's, I think, another challenge, because we rely a lot on the immigrant populations to enhance the Canadian economy as well. So, so I guess maybe those are some of the key points that I wanted to bring to your attention, and I'll stop at that and maybe take on discussion later.
Thank you very much, Zul. So, as Kim mentioned, I'm a resident in psychiatry. I'm at McGill University. I'm in my 3rd year. Actually, I'm realizing now I'm the only resident in the room, which is actually always a fun experience for me, because I don't know who's playing anthropologist, but I think we all are. And I think that's the point of the comments I wanted to bring. I want to give you some context as to what's actually been the most valuable educational experience I've had so far in my 2 3/4 years of residency. And that's a resident-driven and resident-led cultural psychiatry discussion group that a couple of us have started at McGill, which brings together residents with people from a variety of other disciplines, psychology, anthropology, philosophy, sociology, occupational therapy. It's a very long list. And this is something that we have started on our own initiative. It's completely outside of the formal curriculum. We've had the good fortune of having a very well-established social and transcultural psychiatry division at McGill, so that we have a bit of a resource network to sort of get people in, a lot of graduate students. And the reason I'm saying this was one of the most valuable experiences is that it's a non-hierarchical, non-clinical setting where we discuss what we call sort of critical issues in psychiatry, and those are often things that are critical of psychiatry. I made a little list. This is one of the reasons I have this in front of me, because I don't want to forget, of different topics we've covered. They've included things as diverse as the anthropology of suicide, the culture of the pharmaceutical industry, the sort of intersection of psychiatry and issues of postmodernity. And I wanted to actually bring to you a recent discussion we had. It was about 2 weeks ago, where we actually looked at borderline personality disorder, at a feminist critique of borderline personality disorder in context of, actually in conjunction with, I should say, a psychology framework for a dimensional approach to personality. And the point that the author was making in this feminist critique was that there's been a number of ways to position this sort of syndrome that we identify as borderline, either completely intrapsychically, and that's the borderline personality disorder, or completely extrapsychically, which is sort of the advent of the complex post-traumatic stress disorder model. And the argument she was making in this article is that there's a very heterogeneous group of patients. And if you take all of these diagnostic criteria and you combine them all the different possible ways, you could have like 78 different syndromes that would come up. They would all be called under the DSM borderline personality disorder. And she further argued, somewhat provocatively, that it's actually clinicians' countertransference to these patients that helps define a nosology, i.e. the difficult patient makes the diagnosis. And I think this was an interesting point to raise. You can agree or not agree, and I don't think you have to either way. But you see that there's an interaction of our emotional reactions, our beliefs, our cognitions, and how we view the people that we see in a clinical setting. So there's a few points I wanted to bring out of this, and then I'll speak about the research project that I'm undertaking, and I think some of the value of that approach. First, that this is how good research questions are born. It's not by working in silos, it's by going and sitting with people who have very different ideologies and very different sets of certainties from your own, and having all of yours challenged so that you actually have to kind of try to build them back up and see where they hold up and where they don't. And if they don't, then you have to let them go a little bit, which I don't think we're good at. But I think what comes out of that is that categories in psychiatry are not immutable. The older clinicians in this room will remember that 20 years ago was different, and 30 years ago before that it was different. And I'm going to graduate, and there's going to be a new DSM about a year after I finish memorizing all my criteria for my Royal College exam. I appreciate the irony of that. There's a reciprocal relationship between our emotional reactions to people and how we categorize them. It really does cut in both directions. And I think that's important because psychiatrists cannot position themselves as the guardians of mental health and the guardians of patients with mental illness, because if we position ourselves as us and them, like us versus other physicians who stigmatize our patients, we're no further along. We have to recognize, we have to come from a starting point that these are universal, socially constructed reactions, emotional reactions and other. And that leads me, in a sense, to the research that I think is of value in all of this, which is Recognizing that we all have cognitive biases, recognizing that we come with emotional baggage from the cultures, and I say that in a plural intentionally because we all come from several cultures, I think as Zul points out very correctly, and that all of these play into who we are as clinicians. And I think we need to create a buy-in for physicians. We need to have some kind of agreement that we participate in the wider culture like everybody else does. So the work that I'm undertaking is going to tap into some social psychology tools that are relatively new, actually, but becoming increasingly established, where we're looking at implicit associations. So which categories can people easily associate to certain attributes, and which categories do they have difficulty associating to certain attributes? So these are all relative measures, and to illustrate that a little bit, you might look at, for example, and I'll use one that's not related to mental health, mental illness, but you could look at heterosexual and homosexual, and then take a whole bunch of positive attributes and see how quickly you can associate them in a computer test to heterosexual, and then you can see how quickly you can associate all those positive attributes to homosexual, and then you can go through the reverse with negative attributes. And the whole point of that is to say there are some constructs that are more tightly linked to certain attributes in our head, and that's just the way we all think. So that by using implicit measures to at least sensitize people to this is the way we think, we can also tie that into this is what we're willing to endorse. And so looking at the contrast between some of these implicit measures and more explicit measures, where you would say, yes, I would agree to work with somebody with a mental illness, or I would feel very comfortable having someone like who has a diagnosis of X, Y, or Z marry into my family. And we give socially desirable responses. I think it's as with racism, as with homophobia, I think it's all agreed upon. There's some things we shouldn't say too overtly. So I think the last point is to build on what Heather was speaking to yesterday, is that we need to create some kind of link between sensitization and action. So first we have to lay the groundwork for sensitization, and then we have to move forwards into education models that work, that are evidence-based. So, thank you.
Law's relationship to disability generally and mental disability specifically has historically been extremely negative. In Canada, as in the USA, as Patrick demonstrated for us yesterday, law has been a stigmatizer or a facilitator of stigma. And here I'm referring to things like our laws permitting the forced sterilization of people with mental disabilities, laws that have facilitated forced or coerced treatment, laws that allowed people to be locked up in psychiatric facilities with no mechanism for review for the rest of their lives. So lots of the negative myths and stereotypes about people with mental disabilities are grounded in or reflected in our law. The legal history of mental disability is one of exclusion, marginalization, and stigma. Currently, I would say that mental health law in Canada is simultaneously moving in opposite directions. And it's not clear at this point in time if the opposing directions will be reconciled and one of them will dominate, or if we'll continue with this sort of polar opposite approach to mental disability. At one end of the spectrum is the paternalistic, interventionist, punitive law that some legal scholars argue is more of those things these days than it even was 3 decades ago. So under our civil laws, and here I'm relying on the work of Archie Kaiser, mental health statutes make it easier to use the law to compel examinations, detain patients, and treat them forcibly in hospitals, and to extend controls over their behavior into the community. Mental health legislation identifies and provides for the separate care and treatment of people with mental health issues. And through that process, they are segregated and stigmatized. Under our criminal law, we are effectively criminalizing mental health illness. The majority of the people in our prisons in this country have some kind of mental health diagnosis. 30% of them had that diagnosis before they were sent into prison. Criminalization is a huge additional stigma that seriously compounds this problem of the mental health stigma. And of course, those people who are put in jail because they have a mental disability are disproportionately Aboriginal or racialized and poor. The criminalization of people with mental disabilities flows from the stereotypes of violence and aggression that haunt mental disability and the concomitant response of fear. The criminal law reinforces those stereotypes in very public and deeply entrenching ways that are then picked up by the media and popular culture. And I need to add, of course, too, that treatment in prison is very limited or non-existent. So that's the negative side of law's relationship to mental health issues. On the more positive end of the spectrum, we have our human rights laws and our charter, which, at least on paper, offer strong protections against discrimination based on mental disability. We do have a duty to accommodate up to the point of undue hardship, although I would argue that the duty to accommodate, important a step as it is still a very stigmatizing approach to the issue. You need to be accommodated in order to fit into the workplace. We need to address workplace models at a much more fundamental level than the duty to accommodate. We have mental disability expressly protected in our Charter of Rights and Freedoms. And we have a Supreme Court of Canada that has recognized that treating everyone the same does not necessarily mean we are treating them equally. So in Canada, we now talk in terms of substantive equality rather than in terms of formal equality. Substantive equality recognizes and acknowledges that people are different and that equality often requires differential treatment. Also, our Supreme Court of Canada has recognized that the medical model of disability is inadequate to address the equality rights of people with disabilities and has adopted a social model of disability. To me, this is a giant step forward, even though in the very case in which they adopted the social model of disability, they actually, in making their decision, applied a medical model of disability. So, despite what I consider a problematic decision, this case indicates that lawyers are making arguments premised on a social model of disability, and that at least at the abstract level, the court gets that it is the more equality-based, non-discriminatory approach to adopt. That they cannot live up to the application of that analysis should not be surprising given our discussion yesterday about deeply ingrained negative myths and stereotypes that make it hard to really see the implications of accepting that it is our social responses to the person that create the disability, not anything inherent in the person themselves. So in terms of a way forward, if we want to address stigma and discrimination, I believe we have to move away from the medical model of mental illness and adopt the social model, a human rights model, an equality model, and the terminology differs. I think that a shift is implicit in much of what the discussions that we've been having, but I think we have to make it explicit and conscious. Medicine, treatment, and healthcare are, of course, important components of addressing some of the issues, but they are not the whole picture. There is also the social, political, and economic context in which mental disability operates. Part of such a new approach is recognizing the impact that other marginalizing, stigmatized statuses have when they intersect with disability, aboriginality, race, sexual orientation, and of course there is a long history of sexual orientation being listed as a mental illness, or homosexuality, sorry. Gender identity, and poverty, hugely connected. So that's my brief law offering, and so I said I wanted to follow up on a couple of issues from yesterday. The first one is I just want to reinforce Mike's importuning to us of focusing on language and the importance of language and the words we used. I had to catch my tongue about 3 times over the course of dinner last night, recognizing how much ableism and negative associations of mental disability are worked into our language. And I think throughout these 2 days, all of us have been engaging in language that is problematic. So it's so important because it communicates all those myths and stereotypes. Secondly, I'm not familiar with the education contact protest way of describing strategies, but I actually wanted to put in a positive word for protest. I think it's really important that there's protest, and I think it's important that it's strong and that it's loud and that it's in your face. People say it's not effective. But I think that most successful social movements have had a strong element of protest attached to them, and that it is the protest that has paved the way for the other two, the contact and the education, for people to be more open to those items. So I think protest is still an essential part of the work that we do. And it's very easy for us to distance ourselves from the protesters, to stigmatize them, and to see them as the radical crazies. And I actually think the work they're doing is very brave and courageous and really important to the other work that we're doing. The other issue I want to consider, and so it's one that was raised earlier, is what I have is a fear that we are overly focusing on evidence-based approaches. So I'm all for evidence. I'm not negative about evidence. Evidence is important. We use it. We need it. But we tend to have a very narrow notion of what constitutes evidence, and some things are simply not quantifiable. The impact they have may be slow, it may be incremental, we can't attribute it back. We're seeing this in United Way funding now. If you can't quantify it, you're not getting funding. This is extremely problematic. I think we have to embrace intuition and creativity and anecdote and lived experience, both as forms of evidence, but also as other avenues to understanding and to other avenues to change. Because ultimately, that's what we're all working on, is change. Thank you.
Wow. So it's my turn.
Oh, okay. Good afternoon. While I have the microphone, I'd like to say thank you to Kim and Jaime. I know you'll be more eloquently thanked, I'm sure, but it's a great privilege for me to be here today, and I thank you for creating the opportunity. Myself, as a practitioner and a teacher and a researcher, these opportunities for reflection, for engagement, are just so precious, because I always come away stimulated and empowered and full of new ideas and thoughts, and thank you. I'm a social worker, and I've had the privilege of working at the Royal Ottawa for many, many years, and I'm one of the professionals that's grown up in the institution. And I think being a social worker in a predominantly medical model is a very challenging place to be. And we spend a lot of time listening, and we spend a lot of time talking as well, and we do learn together. Social work practices, and my colleague Tim has done a great job, so I don't need to belabor the point, but social work practices at intersections. As the name implies, we're social, we're more than one. So we would practice at that space between law and psychiatry, and mental health practice is very highly regulated. And we're in that space in between. We're in between inpatient and outpatient. We're in between the institution and the community, between qualitative and quantitative. And in those little spaces is where social work lives and develops, and where we learn, and where we make a contribution as well. As a teacher and teaching social work in the school here at Carleton, I start the class in day one by acknowledging that we all have mental health issues, and that our mental health issues is what makes us human. That is our humanity, is our mental health issues. And we start that's day one. When we learn about diagnosis, it's important as social workers that we know what our psychiatry and psychology colleagues mean when they use terms. It's important for us to understand the meaning and how they develop those diagnoses. That's part of what we learn. But an also very important part of making meaning of the diagnosis is inviting people through the Open Minds program into the classroom to talk about the lived experience of schizophrenia, the lived experiences of mood disorders, of addictions. And that is so powerful for the students and for me, for all of us, to begin to create inclusive language, to begin to find the words to respectfully inquire what the impact is of what we do on your life and how your life experience can teach us. That complexity of creating inclusion through the language that we use is a very, very important be continually cognizant of. And so we practice that in the class, and it is extremely gratifying for me. I know that I've succeeded when students feel that they can bring their lived experience of mental distress or interacting with the mental health system into our discussions. And I know, yes, we've created a safe environment, because if we consider that the incidence rate of mental illness is a lifetime incidence of 20%, statistically in my classroom there are going to be people with lived experiences, and we have to be aware of that and be cognizant of the words we're using to create a safe place so that we can learn from each other. I've also been invited to teach residents and in their family therapy program. And when I speak to psychiatric residents about family therapy, I say, well, I'm not going to speak to you about family therapy. I'm going to speak to you about how you can partner with families. And I'm going to remind you of some really good evidence that has demonstrated that engaging family caregivers really improves clinical outcomes. So if you can learn how to partner with these care providers, you are going to see better outcomes for your patients. And one of the things you have to acknowledge when you are partnering with families is that psychiatry, organized psychiatry and families have had a very long and complicated history that hasn't always been conducive to working together. Unfortunately, there was a time when families were blamed for the mental health experiences of their loved ones. So we start the class with the residents by a little bit of an overview of some uncomfortable history, and we start there, but we continue the discussion and we involve including family members as partners in care, and acknowledging that families go through stages of recovery, as does the individual with the lived experience. And there will be times when you'll see a family in an emergency room and you're not going to know where the genesis is. Each and every member of that family is presenting with mental distress. And sometimes what you're seeing is the consequences of living with an undiagnosed, untreated mental illness. And what your skill is going to be is figuring out where you start and where you make the impact with that family, and continuing to engage them, being respectful of law, but also realizing that law is not as prescriptive as we think it is, and unfortunately sometimes law becomes the default for ethical practice. Sometimes a brief, oh, I'm supposed to do this because it says so, takes the place of that ethical discussion. This is the law, what's the right thing to react, what's the right way to intervene at this point in time that's going to move things forward in a way that we're all going to be able to live with in the morning. And so creating space for those sorts of discussions is very important. And I would like also to say that, and Tim touched on this, we do spend a great deal of time thinking of power and privilege and acknowledging power and privilege and the role that has in how we define problems, how we identify them, and how we intervene. And having that segment as part of our discussion is very important with mental health, because there has been, unfortunately, a legacy of abuses of power. And part of our collective healing is acknowledging that and moving forward respectfully, talking and listening to each other and challenging our biases is really the way forward. So those are my very brief comments on social work and how we practice and our role in education and also in practice. Thank you.
Thanks again, all of you. I was a little concerned that when I was putting together the two roundtables that they might be a little redundant, but what very different ideas have just been expressed.